we will skip to the second speaker. According to agenda, we missed about 10 minutes, less than 10 minutes. So our next speaker would be Dr. Ahmed Abdul Salim. He is based in Basra. He will tell us about non-interventional reperfusional therapies in acute ischemic stroke and the role of stroke center. Dr. Ahmed is currently working at Basra General Hospital and lecturer at Basra College of Medicine. He is a consultant neurologist and he is a fellow of Iraqi Council of Medical Specializations since 2013. And he was also a fellow of American Academy of Neurology. So the word is yours, Dr. Ahmed. I'm afraid you are muted, Dr. Ahmed. Please unmute.
Hello, everyone. Thank you, Dr. Mustafa, for this nice introduction to me. I hope in this presentation will be complementary for the other lecture presented previously from my other colleagues. I will speak today about non-interventional reperfusional therapy in acute ischemic stroke, and we will highlight about the importance of stroke center in this situation. So, the objective of this presentation is to clarify the role of stroke center in the management of acute ischemic stroke and to identify the importance of reperfusional therapy in the management of acute stroke center and to answer the question, is it applicable in our locality to establish a stroke center? What is the importance of stroke center? Why we are insisting to establish a stroke center to provide care for a patient who is victim for acute ischemic stroke? Because the stroke center is aimed to provide an specially trained person which is capable of dealing with different aspects of acute ischemic stroke management. What are these needs that are established by stroke center is to establish the diagnosis as early as possible, to provide reperfusional strategy because these treatments are the most effective intervention for acute stroke, and to provide adequate hemodynamic management, monitoring and management of acute ischemic brain edema, and early recognition and therapy of systemic complication that may occur in patients with acute ischemic stroke. What are the three main principles for the treatment of acute ischemic stroke? Is to achieve timely recanalization of occluded artery and reperfusion of ischemic tissue, and to optimize collateral flow and to avoid secondary brain injury. For the second one, is usually achieved by giving isotonic fluid, normal saline or ringar lactate to improve collateral. And this is part of acute stroke management, and also it is could be part of secondary stroke management. While the third one is to avoid secondary brain injury, is achieved by prevent complications that may arise from different situations. For example, hyperthermia, hyperglycemia, hypoglycemia, other. So our main goal in acute stroke management is to achieve timely recanalization of the occluded vessel. And why this is important? Because even if the patient get infarction, there is an area around the ischemic, around the infected area, which is an ischemic, but not yet to get infected. This is called ischemic penumbra. If we get reperfusion to this area, we will salvage this area and we will improve the neurological outcome by a lot. How we can achieve recanalization? Either by use the chemical thrombolysis, using recombinant tissue plasminogen activator, which is also known as alteplase, and by mechanical embolectomy with retrieval stents. So, for acute reperfusional treatment, there is an incontrovertible evidence that IV thrombolytic with RTPA and endovascular thrombectomy with retrieval stent improve neurological outcome in patients with acute ischemic stroke. And there is around more than 200 randomized controlled clinical trial that show the efficacy of tissue plasminogen activator in the treatment of ischemic stroke. Some of them are mentioned by Dr. Sarud, NANS, and CMA3 and others. But we have a time limit in order that we give the tissue plasminogen activator, which is about 4.5 hours from symptom onset. So in order to treat a patient with acute ischemic stroke, we need to take these consideration in our management plan. The first one is the time in which the patient was learned to be well, because the time limit is very important, and we are limited for only 4.5 hours to give the thrombolytic agent and only 6 hours for giving doing interventional cath, and maybe extended for special by special consideration into even 16 to 24 hours. The medical condition or recent surgery that could be contraindicated for thrombolysis, and we should do a neurological examination to calculate the NIH score. And we, in the further slide, we see what is the importance of these points. And we should also take a capillary glucose level. We should also measure the blood pressure, and we should obtain a brain CT scan to exclude intracranial hemorrhage. The most beneficial time in which the patients can benefit from RTPA is about 90 minutes. The standard dose of IV RTPA for acute ischemic stroke is 0.9 milligram per kg with 10% administered as a bolus, and the remainder infused over 1 hour. But the total dose should not exceed 90 milligram. Why we ask about the question previously taken into consideration in the management of acute ischemic stroke patient? Because there is contraindication. These contraindications should be put in our mind if we want to give thrombolytic therapy, which are severe trauma in the last 3 months, ischemic stroke within the last 3 months, arterial puncture at non-compressive site in 7 days, previous intracranial hemorrhage, suspected subarachnoid hemorrhage, if there is AV malformation, if the systolic blood pressure is above 185 over 110, and the blood pressure should be reduced to 180 over 105 before giving thrombolytic therapy. If there is bleeding diastasis, if the patient take warfarin INR is above 1.7, if the patient take warfarin within 48 hours with abnormal APTP time, the platelets, if it is less than 100,000, and if there is current use of thrombotic inhibitor within 48 hours, and the blood glucose is less than 50, or if the CT show hypodensity more than third of the hemisphere. Other relative contraindication are minor stroke, if the NIH score level 5, if there is rapidly improving symptom, pregnancy, seizure, because it may be part of thought paralysis, major cranial trauma, major surgery within 14 days, or gastrointestinal genitourinary surgery within 21 days, or acute myocardial infarction within 3 months. And there is additional contraindication if you want to give the patient a thrombolytic therapy from 3 to half and a 4.5 hour window, which is if the age is more than 80 and warfarin used regardless of the INR, and if the IH score more than 25, and if there is a previous stroke or diabetes mellitus. So, what we need in our locality in order to succeed in establish a stroke center, the most important is to educate our people about the stroke symptom and the importance of bringing the patient as early as possible to the hospital. And this can be carried out by media, by television, and by poster, which is maybe globally distributed all over the country. And to provide good trained medical personnel that are carefully choose the eligible patient for reperfusional therapy and are capable of dealing with stroke management aspect. And in our institution, we should have a stroke center which is capable to doing a brain CT scan and other modalities of CT scan, CT perfusion, CT angiography, and as early as possible, because the time is the key for success in treating patient with acute ischemic stroke. And this should be carried out by our health institute manager, should provide us with our need, CT scan and cath lab in order to make the stroke center work in our locality. So as a conclusion to my talk, acute stroke is a medical emergency in which every minute is count. Achievement of reperfusion can reverse neurological deficit, even severe, and allow patient to regain function. Providing nearby or portable CT is a major limitation to establish stroke center in our locality. Finally, I would like to highlight about my experience about giving RTPA in Basra. I give RTPA for 5 patients. 3 of them are recovered completely. 1 of them are only partially recovered. 1 of them, of the patient, which was female, about 80 years, have large MCA stroke, not respond, and eventually die in the ICU. So RTPA and other management of acute ischemic stroke, mainly the reperfusion, make a lot change in stroke treatment and should be considered and to be implemented in our institution. Thank you for all.